Welcome to Let's Talk About Health, powered by Focus on Diabetes. Focus on Diabetes partners with accredited doctors to share education and new treatment options, world class healthcare organizations to introduce new technologies and free screenings for diabetic patients, their family, and the community. Now, let's talk about health.
Hi, everyone. Welcome to Let's Talk About Health. My name is Tiffy, and I have with me today Dr. Mark Burkard. He is the director of the University of Iowa Holden Comprehensive Cancer Center at the University of Iowa. He is a medical oncologist, which means he gives medications such as chemotherapy and hormone blockers to treat breast cancer. He also studies genes in breast cancer and how they affect which medicines work. So, Dr. Burkard, if you want to kind of give us a little spiel about yourself.
Sure, it's wonderful to be here. I joined the University of Iowa about 3 weeks ago. And I'm originally from upstate New York, did a lot of stuff in New York State, and then came to the Midwest to raise a family 16 years ago in Wisconsin. And now I'm converting from Badger fandom to Hawkeyes fandom just in time for a big game this Saturday.
Perfect. Go Hawkeyes. How about you? If you want to tell us a little bit about what you do at the University of Iowa Cancer Center, Holden Cancer Center.
Yeah, so I'm the director of the Holden Cancer Center, and the mission of the Cancer Center is to defeat cancer comprehensively through prevention, screening, treatment, and through discovering new ways to beat cancer. And part of our mission is to serve the entire state of Iowa. So one of the important goals is to reach out, to connect, to find ways to reach people wherever they're at, to share information, to help them find their way, to help them get the best possible treatment for cancer if they are unfortunate enough to have it, and to discover new ways to do better. And so that's why it's a pleasure to be here with you today, Tiffy.
Okay, awesome. So, well, I'm just going to start with since you specialize a lot in breast cancer, um, if a person is coming in, like, where do they start when it comes to breast cancer? What to look for? Should they start with their primary? And, a lot of people use a lot of Google. So, if you want to kind of let us know the process.
Right. Breast cancer can show up in many different ways. And so what we like to do is find it as early as possible. And it could show up on a mammogram, which is recommended once a year between the ages of 40 and 75 for screening. Or if you have a symptom. So if someone notices a change in their breast, a new lump, a new dimple, a new hard area, it can show up in many different ways. So if there's a change, what you want to do is reach out to your physician, your general physician, and let them know, have them do an exam usually. And then what they'll often order is something called a diagnostic mammogram, which is different than the one you have annually for screening, because the diagnostic mammogram is focused on the area that the change is at. And whether it's found, something is abnormal on the diagnostic mammogram or a screening mammogram, there the radiologist may recommend a biopsy, which is a needle sampling a piece of that abnormal area. And that's what can tell us whether it is or is not breast cancer, and if it is, what type. Most people who have scares on their exam or on the screening mammogram will not have breast cancer. It'll be something to watch or something that's not cancer. Some people will, and those people need help with a specialized surgeon, and often a medical doctor like me, and often a radiation doctor. And so your doctor would then refer you to a cancer treatment team like the one we have at the University of Iowa.
Okay. Well, that's good. That's great information. Is there, from the time after mammograms, because I think with some of the changes, I think they were talking about also with mammograms switching from yearly to bi-year, like twice a year.
Yeah.
Do you think that would affect any type of way when it comes to women and breast cancer?
Well, in the United Kingdom, every other year is recommended because it turns out doing it every year doesn't save that many more lives, but it saves a tiny number of more lives. But the reason we often recommend it every year is because it's easy to miss a mammogram and be a little late. And if we recommend it every year, then most people get it on a regular basis. To be clear, the mammograms tend to find the less aggressive cancers. When you're doing a test once a year, you're only looking once a year. So in between those mammograms are when the highly aggressive breast cancers can show up. And unfortunately, although African Americans have lower risk of breast cancer than white women, they also have a higher risk of those cancers being the aggressive type. So we do recommend annual mammograms, but also that awareness for breast changes, even if you had a mammogram a few months ago, because that could be a different type of cancer that's showing up.
Okay. So is that, we'll say if a woman, or African American woman, she had her mammogram within a year, and then a few months later, after checking, notices something, how would that process look likely different after with being within that 2-year mark of having her mammogram if she did her self exams and finding something?
Yeah, I think whether or not you're up to date on your mammograms, if you find a new lump or something out of the ordinary, that's a time to consult with your doctor. And as I said, it could be a lump, it could be a dimple, it could be a nipple inversion, it could be a red area. I've seen patients where it starts with a swelling in the armpit. It could be any of those things that are how it first appears. So that is, an indication to go see your doctor. Now, some people have what are called fibroadenomas, which can change with the menstrual cycle. And so sometimes your doctor might recommend that you wait a couple of weeks if you're premenopausal to see if it dissipates. But in most cases, they will want to get what's called a diagnostic mammogram, which is different than the screening mammogram, to see if that abnormal area is suspicious and whether a biopsy is needed.
Okay. So let's talk a little bit about the disparities when it comes to breast cancer amongst African American women, minorities here in Iowa, since Iowa does have, what are we? Are we number 2?
Number 2 in cancer incidence for the whole state. Of all the 50 states, we're number 2, unfortunately.
Right. So yeah, if you want to give us a little bit of information on that.
Sure. And what we're finding is in different parts of the state, there are different risks, and different cancers are driving the high rates that we have in the state. They include lung cancer, melanoma, but most relevant to the African American community is breast cancer and prostate cancer. Those are increasing and those are driving the changes in Iowa. We think some of this is related to risk factors we don't control. Like when we get older, we are at higher risk of cancer. There are the number of pregnancies and children you have, and when you start your menstrual cycles and when they end, all are cancer risk factors for breast cancer. Mm-hmm. But we don't control all those things, and some of the things we control for other reasons about family and so forth. But there are there are some risk factors we do control. Relative to lung cancer and bladder cancer, it would be smoking. Relevant to breast and prostate cancer, though, I think it's mostly about diet, obesity, and exercise. And having a well-balanced diet, maintaining a healthy weight, and regular exercise, which some people recommend to get as close as 90 minutes a week of aerobic exercise. Those are the best we can do. But even that doesn't prevent it altogether. I mean, that's a lot. I don't accomplish that, to be honest. And, that doesn't prevent it. I've had patients who run marathons who have breast cancer. And so there are parts of this outside of our control. So we want to be careful not to blame people for getting it. The other part of the disparities is African American men are at higher risk of prostate cancer compared to other groups. And this is really important for the African American population. And the way that is best addressed is through talking with your physician and getting screened. For some men, like white men, often screening is recommended at 50 for prostate cancer with a blood test. For African American men, it's usually recommended to start earlier. So that's an important discussion that people should have with their doctor. With women, as I said, on average, the cancer rates for African American women are less than white women. However, the cancers are more dangerous when an African American woman gets it. And so that's why it's especially important to be aware of breast changes and not just rely on mammograms. I've had so many patients who said, well, I knew I was getting another mammogram in 6 months, so I didn't do anything about this breast lump or this red spot. But that should be something you bring to the attention of your doctor within a week or two.
Okay. So within a week or two, is there ever any, like, when it comes to disparities and diversity, like when I've worked in oncology before, we would have some patients that were like, okay, I'm going in, got this diagnosis, want to see this oncologist, and then, you know what, I think I want a second opinion. Is there a time in between that? Like, my opinion, how I feel is I don't think you should ever really, I don't believe in like, oh, I'm going to wait until I get this second opinion and do this and do that. How would you approach that if a patient, okay, well, I'm coming here, I'm seeing you, but I also want a second opinion. Should I wait during this time to do this? Or would it be better for me to go ahead and get started? And kind of like if somebody's like in between that and they feel like I got breast cancer, this provider wants me to just go. I'm scared. I'm nervous. I kind of want to maybe see what else is. How would you approach that? Because I've seen that a lot in some African American women before, and it's like, oh, we want to wait. I want to get the second opinion. I don't believe, So how would you kind of approach that? Or if you've ever even seen that before?
Yeah, I've seen that a lot, and people handle that in different ways. And it can be hard because some people, sometimes to get a second opinion may take weeks or months. There may be insurance barriers to doing that. And it depends really on the type of cancer, whether it's safe to wait that long to get started. So what I find is most people choose to get started and then sign up for that second opinion. And that second opinion is given after some of the treatment has begun. So that does. So I think what I would recommend is, if you're thinking about that, you should ask your physician who's giving you met first, whether you can safely wait 3 weeks, 6 weeks, or however long it takes. I've had patients work through insurance issues for 4 months.
Oh my God.
And then you say, like, it's maybe not safe to do that. What we're hoping to do at the University of Iowa, which we haven't quite done yet, is help all the oncologists in the state give the best care for their patients by doing what we call televisit second opinions or collaborative care, where we can have one of our expert specialists in each cancer type work with your local oncologist to develop the best treatment plan without you having to drive across the state. And one of the leaders of the team that's helped organize this, Dr. Rahim lives right there in Waterloo and is very motivated to do that. So I think there's a lot of opportunity to do better there. But right now, we haven't really gotten that project rolled out very well, simply because there's so many people struggling with cancer right now.
Mm-hmm.
We are struggling just to get enough doctors and nurses to take care of all the patients who come to our clinic.
Oh my gosh. Okay. An audience that's out there, I can't really see who's there or not. Definitely pop some questions in if you have any questions when it comes to breast cancer and disparities, because we love questions, of course. And one here is there a difference in racial disparities in cancer and bio or genetic disparities in cancer?
There's definitely a difference there. So as we say, race is a social construct. Like it's not necessarily purely genetic. Our differences that skin color is what we describe as race. But in any case, some racial disparities come from social factors, as you might imagine. Like many African Americans have less access to healthcare because of their neighborhood or the many other factors that are social, not genetic. But there seems to be also some genetic predisposition, also that's racial, and that was why I described the risk of prostate cancer being higher and the risk of breast cancer being lower, but the bad breast cancer is more prevalent. I'm at a conference actually out of town today, and we just had a talk about whether African Americans and other races are more carry a gene that runs in the family that predisposes them to breast or prostate cancer. And the conclusion of this study was that there are tiny differences in different racial groups, but they're not very strong. And so if there's a family history or a risk factor that we suspect there's a gene that runs in a family causing the cancer, we shouldn't really consider what race or background someone comes from. We should have our patient be the genetic counselor, get a blood test and look for a gene, because if we find a gene that's causing, say, breast cancer, that would allow us to identify other family members that have that same risk, and we can do things to prevent them from having cancer or to screen for cancer more intensely.
Is that when a lot of the genetic testing kind of comes into play with that?
That's right. We know about 5% of breast cancers are caused by genes called breast cancer or BRCA1 or breast cancer or BRCA2. And those genes are very important to find, because if you're a woman and you carry one of those genes, your risk of breast cancer in your lifetime will be 60%, whereas the average woman, it's only about 10%. And so when we find that, we talk to people about prevention, about screening, and what we can do so people don't get breast cancer. And when people do get breast cancer with those genes, it actually changes some of the medicines that work to control the cancer. So it's very important to know that, not only for the person with cancer, but for the family members. And if you carry that gene, let's say you're a mother and you carry that BRCA1 gene, then your children, your daughters and your sons could find out if they have it, and they would have a 50% chance of inheriting that same gene, or 50% chance of not. So they could find out their personal level of risk of breast cancer. The BRCA2 that I talked about also confers a pretty big risk of prostate cancer. So if you find that, you would want to know in both the men and women in the family.
Okay. Because I was wondering with that, because I'm like, me being a mom, don't have breast cancer, which is great. But if there was ever an instance where I had a family history and that BRCA gene was there, me having a son, that could possibly affect him as he gets older and when he should be tested, right?
That's right. Especially that BRCA, there's two of them, number 1 and number 2. Especially number 2 increases the risk of prostate cancer. And although the risk is smaller, pancreatic cancer. So it's important to know that.
Okay. There's a question down here. The statistics of African Americans with breast cancer, including men with breast cancers. Is the increase in breast cancer due to men or women or both?
With men, the risk of breast cancer is about 1/100th of women. So if, because men tend to have less estrogen in their bodies during their lifetime, whereas women have menstrual cycles and the ovaries make estrogen every month. And that cycling affects the growth of the breast cancer precursor cells in the breast. So men have a relatively low risk of breast cancer. It would be higher if they inherited a gene like BRCA2. We don't see a higher risk in African American men of breast cancer than white men, for example. But we do know the risk factors for male breast cancer are BRCA2, a very, very rare syndrome called Klinefelter, and people who have a lot of obesity, because the more fatty tissue you have, even if you're a man, the more estrogen that circulates in your system. So those are the risk factors, but it's still a lot less than women.
What is your suggestion for people that want to treat their cancer with natural cures?
Well, I think you have to be careful there, because we are all human, and we humans are driven by stories. And stories can be very interesting, but sometimes they can be misleading. And so if you're getting your information about natural cures because someone said they did that and they were cured, well, sometimes if you look a little deeper into that story, it's not quite what you've heard. So as a physician, what I want to do, if someone says A cures B, I want to ask them, how do you know? I want to say, I don't want to just hear a story. I want to see the medical records. I want to know how often that story happens. I want to ask them how many people did that and died, so you're not telling me the story.
Right.
So I think you have to, sort of logically process the question of how you know. As physicians, we are trained to, and nurses, we are trained to do that. And so that's why, what I would recommend, the best thing to do, because it's hard to parse this kind of information. We have a lot of stuff coming at us. It's hard to be an expert in everything. We all have our careers and areas of focus that we are expert in. But when you get out of your field, how do you know? So I would go talk to your doctor there. I would talk to other medical professionals. But if someone is telling you something that doesn't quite sound right, or it's too good to be true,
it's too good to be true.
It's probably too good to be true.
I agree. What is your focus area while at the University of Iowa?
Yeah, the reason I'm excited to be here and my focus is making sure we take care of all the people in Iowa. And that's why I'm here tonight, because taking care of all the people in Iowa is a major mission of the Cancer Center. Right now, there's really rapid changes in cancer care. And I think it's very positive. We went from an era where most people died of cancer. We have people like, you might remember Jimmy Carter, who had melanoma in his brain 10 years ago, and he's still alive. When I was a medical student, people with melanoma in their brain had less than 6 months to live. There are treatments that remarkably have made a difference in cancer.
Right.
But at the same time, what's happening is it's getting more complicated. There's not one cure for all cancers. There's not even one cure for each type of cancer. Each type of cancer has many, many different treatments, and you need more expertise and information to select the best treatment for each patient. And the future of oncology is going to be difficult to deliver in rural communities unless we're very smart about how we do this. Because if I'm a general cancer doctor who does every type of cancer for whatever patient walks in my office, I can no longer be an expert on everything. So at the University of Iowa and the Holden Cancer Center, our goal is to help your oncologists in your community have the ability to tap into that expertise and develop an expert treatment plan for that specific type of cancer, but for you to get care in your community, whether that's in Waterloo, whether it's in Atlantic, whether it's in Spencer, anywhere in Iowa. We want to deliver the best care possible, given the increasing complexity of figuring out what the best plan is, by having our experts advise you and your physician without you having to come all the way to Iowa City.
Okay. That's good. So is there, some people it's like, okay, well, I have this diagnosis, chemotherapy, I can't handle it. It makes me feel like this, which not everybody will handle chemotherapy the same. Everybody's chemotherapy is not the same, whether some people believe like, oh, I have breast cancer, this is my regimen. Oh, this one had this regimen. Some
Right.
people will think like everybody has that same type of chemotherapy, whether it's chemotherapy, radiation, cycles, and treatments. How would you explain when it comes to the different therapies and regimens when it comes to people taking chemotherapy? Because it can be harsh, but sometimes I feel like some people's like, well, I don't want to do this chemotherapy. It makes me sick. It's killing me faster than my cancer.
Mm-hmm. I think that's a difficult one because I've heard from many of my patients and my own personal family. I've seen loved ones go through chemotherapy, go through radiation, and we often see things that were very difficult for them. And sometimes it's 10, 20, 40 years ago if it's a parent. What I can say is things are different for each person and things are changing. For example, in the past 10 years, we've had some of the best medicines to prevent not feeling sick or vomiting, such that is extremely rare now. I mean, that was the first thing I heard from many of my patients. My mother had this and got this chemotherapy. So some of my patients say, gee, I didn't expect to have it like this, because when I saw someone 10, 20 years ago, it was completely different, but also different in different types of cancer. They're not all comparable. But the other part of it, there's two more parts of this question I want to answer. One is, as your physician, your oncologist is responsible for making it tolerable. The goal isn't to stop your life and to be sick for 6 months. If the treatment is causing particular effects in you, your physician is going to work with you to improve that. And so usually there are checkpoints before each dose of chemotherapy, if you're getting chemotherapy, to try to make it more tolerable and to manage those symptoms better. The second point, the final point I'd make is we are entering the era where we're replacing chemotherapy with new medicines that are not chemotherapy. Jimmy Carter got immunotherapy. It's not chemotherapy at all. It's an IV medicine that revs up your immune system. For many people, it has no side effects, but for some people, it causes some problems like autoimmune disease, completely different than chemotherapy. So there's a lot of new things that are starting to replace chemotherapy. That's not to say it's not hard on some people. It's going to be hard in certain circumstances, certain people, and you and your doctor need to work on that the best possible to make it tolerable.
Okay. In what phase of care would someone come to see you?
Usually I would see a patient when they're first diagnosed with cancer. For me, it's breast cancer. Usually there would be a check-in with a surgeon and a medical doctor like me. Some people would see the surgeon first if we knew surgery was the best thing to do right away. Some people might see me first if we knew it was an aggressive cancer where chemo drugs need to be used first. But usually it's right when you are diagnosed with breast cancer that you would see me and a surgeon. And we would check on you, we would go through the treatment, which may take months. And then we would work to do regular check-ins after the treatment is over every, say, 6 months for a few years.
Okay. So are the men who are transitioning into women who take estrogen have a higher increase in breast cancer, or the transitional individuals make up the increase of breast cancer candidates?
Oh, that's such an interesting question. And I have had patients who fell into this category. Certainly by taking estrogen, you do change your risk as a man of getting breast cancer. And so it's not clear whether that risk is as high as being a woman. The average woman lifetime risk is 10% in the lifetime. So it may get you up to 10% or close to it. But we don't have enough information about the risk on people who are transitioning. We do have enough information that estrogen is a risk factor. But people make these life choices for other
Right.
reasons, and they're pluses and minuses of any of that.
Right. Because I was wondering also with right before we wrap up, with males not males, but or is it with prostate cancer, with guys transitioning that still have their
Well, if
prostate?
men transition, male to female transition might have less testosterone exposure, so
Right.
may lower the risk of prostate cancer. So again, these are shifts in cancer risk that may be affected by lifestyle, but I don't know that your overall risk of cancer would be affected by that.
Okay. Well, once again, Dr. Burkard, thank you so much. Great information. If you want to let us know and let the people know how they can contact you.
I have an email. It's my name, mark-burkard@uiowa.edu. And my phone number for the clinic is 319-356-4200. I specialize in breast cancer, but if you need another cancer specialist, I and my clinic can help direct you to the right person.
Okay, perfect. I hope everybody got all that information. We know breast cancer is out there, and definitely with African American women, things being more aggressive when it comes to us. Just everybody take in that information. Do what you supposed to do. Don't wait. Any final comments from you, Dr. Burkard?
Yes, it's Breast Cancer Awareness Month, the last few days. So take care of yourself, take care of your loved ones, encourage people to talk to their physician about screening, and we are here if you need us.
All right, perfect. Thanks, everybody.
Thank you. Bye.